Hello, welcome everybody. It's my pleasure and honor to hold this webinar about the echocardiographic evaluation of right ventricular function. And in my talk I would emphasize the added value of three-dimensional imaging. Attila Kovacs, I'm Chief Medical Officer of Argus Cognitive. Here at the Argus Cognitive we developed the revision method which aims to more thoroughly quantify right ventricular function based on three-dimensional echocardiography, and I would incorporate the revision-derived information and current knowledge base into my talk. I'm also assistant professor and a clinician cardiologist at Samuel University. Please note that after my presentation there will be a little time to answer your questions, so if you have any questions, just please feel free to get it into the chat box, and I will try to address your questions at the end of my presentation. So first of all, why we care about the right ventricle. You may know that this is less studied due to the complex geometry and function. There are also numerous therapeutic options for the left ventricle, and however, we face an increasing number of right heart failures in current clinical practice. Just to have you some example on the prevalence of right ventricular dysfunction, about half of the heart failure with reduced ejection fraction patients have right ventricular dysfunction, which also carries a significantly increased risk of adverse outcomes. It is even more dramatic when we are talking about heart failure with preserved ejection fraction, where the 2-year mortality is about 45% for those patients who has accompanying right ventricular dysfunction. And the data are even more shocking if we are looking at this beautiful paper from the Mayo Clinic based on more than 64,000 consecutive transthoracic echocardiogram examinations, where the authors find that at least mild RV dysfunction is present in over 21% of the patients, and severe dysfunction is present in 4%. Excluding patients who underwent cardiac surgery, heart transplantation, assist device implantation, or having congenital heart diseases, well, actually these are the at-risk, the patients of this cohort, the 1-year all-cause mortality with excluding these pathologies was still about 40%, and 5 years over 60%. So I think this is dramatic, and we should target right ventricular dysfunction, both diagnosis and the therapeutic development should target right ventricular dysfunction because it's a severe clinical issue. If we look at what causes right ventricular dysfunction, we can see that it is mainly attributable to left-sided cardiac diseases, and interestingly, RV dysfunction associated with left-sided cardiac diseases have worse outcomes compared to even pulmonary artery hypertension. And why we think echo is optimal for assessing the right ventricle and right ventricular dysfunction. It is a fast, non-invasive, cost-effective way, and we get a comprehensive picture of both cardiac structures and blood flow. However, as you may see, we have several different functional parameters describing the RV, and maybe even the number of these parameters tells us that there is no one that will tell the entire story. And also, you may notice that the majority of these parameters are referring to only the longitudinal shortening of the right ventricle. I mean, tricuspid annular plane systolic excursion, TAPSE, TDI, or 2D spackle tracking derived longitudinal strain, and actually these measures are neglecting non-longitudinal mechanical components. As you can see in these two examples I've brought you, the first one is a completely normal contraction pattern and a completely normal RV, contracting indeed mainly in the longitudinal direction. However, the other patient is a heart transplant patient who has actually perfect ejection fraction and good right ventricular function. However, longitudinal measures should be all decreased, and we can see that this RV is rather contracting in other direction, namely the radial direction, and this generates ejection. The idea and the development efforts started with heart transplanted patients coming from my clinical practice, where I would like to have a quantitative method to assess the non-longitudinal mechanical pattern, to assess and quantify radial RV motion, to understand what's happening in different clinical scenarios. But what is the physiological basis of the different mechanical directions? So it is originating from the myofiber architecture, and indeed the subendocardial layer is mainly oriented with longitudinal fibers. However, at the subepicardium you will find circumferential fibers that are actually contiguous with the left ventricular fibers. So even the myofiber architecture points at that not just the longitudinal shortening will contribute to RV function. Currently, we are distinguishing three different specific motion directions when characterizing the right ventricular motions. First is the longitudinal, of course, shortening of the longitudinal axis with traction of the tricuspid annulus towards the apex. The second that we call the radial, so this is the inward movement of the right ventricle free wall, also called as the bellows effect, as you may appreciate at the two-dimensional echo video next to the bellow. And the third one, and this is really interesting, I will talk about later, is the anteroposterior direction, which is the shortening of the anteroposterior axis due to the contraction of the left ventricle, due to the circumferential fibers of the left ventricle, which are then pulling the RV free wall insertion lines towards each other. Let's dig a little bit deeper with current two-dimensional, let's say conventional echocardiographic parameters. We have TAPSE, which is simple, easy to measure. Decreased values are correlating well with morbidity and mortality, and actually, and to be honest, this is a very powerful measure of right ventricular function. However, it refers only to the longitudinal shortening, heavily affected by preload changes, and as I showed you, for example, in that heart transplant patient, its values after an open heart surgery are not reflecting global function. Here's a clinical example of that. These two patients has actually the same value of TAPSE, namely 9 millimeters, and you may appreciate that the patient on the left side has severe RV dysfunction, while on the right side this is normal RV function. We have fractional area change, which actually incorporates radial motion as well, and there is several studies showing that it correlates better with CMR-derived RVEF data. Therefore, it can be really incorporated in such post-operative echocardiographic examinations. Still, clinicians are reluctant to use it. This is because of the limitations, as the endocardial delineation is not that easy in every patient, which results in poor reproducibility. And also we have to emphasize a physiological phenomenon. At the bottom you will see that fractional area change is actually referring to a single two-dimensional cut of the right ventricle, and actually neglects the huge surface, the huge free wall surface. Therefore, we lose significant information with fractional area change. We have tissue Doppler imaging getting us both systolic and diastolic functional parameters. There are even more diameters we can derive from it, like the myocardial performance index. However, it is still referring only to the longitudinal shortening, and of course carries all those limitations that Doppler-derived measures will carry, like the angle dependence. Longitudinal strain. It's no question this is a step forward in RV assessment with a better reproducibility, sensitivity, providing segmental information and proven value in several clinical scenarios. However, it has still limitations. It still refers to longitudinal shortening and still carries the same load dependency as the aforementioned parameters. Now we have three-dimensional imaging by transthoracic echocardiography, and actually by transesophageal echocardiography as well, which I think is a breakthrough technology in cardiology in general, but also concerning the assessment of the right heart. So we can calculate right ventricular ejection fraction. We have volumetric measurements without geometrical assumptions, but of course there are still limitations, like the feasibility. In good centers it is up to 80, even up to 90% of success rate. Previous transducer technologies needed multi-beat reconstruction, and there is an established underestimation versus cardiac MR based volumetric assessments. So how to justify three-dimensional ejection fraction and three-dimensional imaging for the right ventricle assessment? There are momentous studies showing that a lower right ventricle ejection fraction was associated with incident heart failure or death independent of left ventricular ejection fractions, even in those patients who was actually no history of previous heart failure events. And also it seems like justified that the impairment of right ventricular ejection fraction carries a significant association with adverse outcome, and this significant association is actually independent of left ventricular ejection fraction. So that common sense is that RVEF will just reflect left ventricular dysfunction is certainly not true. Recently, my research group at Semmelweis University performed a meta-analysis involving about 2,000 patients, and we investigated the relative prognostic value of different right ventricular systolic functional measures. What we can show is that three-dimensional echo-derived right ventricular ejection fraction was clearly superior and much more closely associated with adverse cardiopulmonary outcomes compared to both tricuspid annular plane systolic excursion, fractional area change, and importantly also free wall longitudinal strain by two-dimensional speckle tracking echocardiography. However, what happens when we would like to think even forward on three-dimensional echo-derived right ventricular ejection fraction? There are even, let's say, older studies showing that, for example, the transverse rather than the longitudinal motion is reflecting right ventricular ejection fraction, or showing even the regional or let's say segmental dysfunction in different cardiac diseases. So we may think that there is an added value of post-processing three-dimensional echo-derived RV models and look for mechanical patterns and look for segmental dysfunction. This is an example of shape analysis. Actually, the curvature of the different RV shapes is depicted on these two models. The first is a normal, the other is a pulmonary hypertension patient, and you may see the shocking difference in this visually enabled parameters, and of course these can be measured and these can be associated with dysfunction and outcomes, as beautifully shown by Karima Detia and from Roberto Lang's group, showing that these changes in shape actually are associated and provide a quantitative evaluation of RV remodeling that can be then used to track the changes of RV shape and maybe enable us to assess disease progression or regression. And I would like to talk about now the revision method, which is developed by Argus Cognitive, and our approach in providing a more detailed, more thorough investigation and characterization of the RV is rather functional. At the left side you may see this blue RV model, which is the global mechanical pattern of the RV, and we can, with the revision method, decompose its motion along the three anatomically relevant orthogonal axes. Namely, at the orange model, you will see that this model is contracting only in the longitudinal direction. At the yellow model, you will see that this model is contracting only in the radial direction. You may appreciate the bellows effect beautifully, I think. And there is the third one, anterior-posterior, which can be also quantified. Actually, what we do is we measure ejection fraction values of these separated, let's say, axial models of the RV. So we can calculate longitudinal ejection fraction, radial ejection fraction, and anterior-posterior ejection fraction, and that's how we quantify the mechanical pattern of the RV. However, revision is not just capable of this motion decomposition, but we also implemented segmental analysis, namely a volumetric segmentation into 15 subsegments, and we can analyze the volume loss and also strain values of these segments, enabling to detect segmental RV dysfunction. And we also introduced circumferential and longitudinal strain quantification, however in a three-dimensional manner. So actually we use the entire surface of the RV model to quantify circumferential and longitudinal strains. How it looks like. Current version of the revision is based on the reconstruction of three-dimensional right ventricular models that can be done by a commercially available software, and if we use this 3D RV model as input to our software, then it will preprocess it, segment it, and calculate it automatically. Those measures I've already mentioned, like longitudinal ejection fraction, radial ejection fraction, strain values, and so on. We tried, it's not that easy to validate three-dimensional models because CMR-derived 3D models are not easily reconstructed. So in that regard, 3D echo is an easier and more straightforward technique to work with three-dimensional models, but we did a validation study and actually showed that there is good correlation, good agreement between CMR-based and 3D echo-based measures of this special mechanical pattern parameters. Let's talk about different clinical scenarios. So when we can face a shift in contraction pattern and when the revision method can be of clinical interest. So when, of course, there is a change in the Myofiber architecture. So it can be congenital. For example, we know that in different congenital heart diseases like tetralogy of Fallot, there is a different myofiber architecture compared to healthy controls. And of course it can be acquired, so actually volume overload or pressure overload will result in a change in myofiber architecture. Left ventricular remodeling will result in the change in RV myofiber architecture, and that will have of course results corresponding to the mechanical pattern of the chamber. Opening of the pericardial sac, losing pericardial constraint is another factor that will result in an instant shift in the contraction pattern, and concerning heart transplanted patients we also can face the denervation. So let's just have another clinical example. On the left side you will see a patient with severe primary mitral regurgitation with a good TAPSE value. However, after the open heart surgery and mitral valve replacement, you see that this contraction pattern is actually changes. TAPSE value is abnormal. However, if we qualitatively see at this RV, this is still contracting well, and we would not say that this is dysfunctional. And this is because there was a change in the contraction pattern, and now radial function will actually dominate the contraction pattern of the RV. So first of all, to investigate the different mechanical patterns, we have to know what is normal. So the conventional belief was that the longitudinal motion is the far dominant shortening and the far dominant component of RV pump function. We investigated 300 healthy volunteers from different ages and with different gender, and actually, yeah, for sure there is some change in the mechanical pattern with age and gender, but overall we can see that the relative contribution of longitudinal, radial and anterior-posterior components are similar. So we are starting from a balance between these three different mechanical directions, and now we can check what's happening at different clinical scenarios. Importantly, I would like to mention that we also looked at what are the determinants of the different mechanical patterns, and for example we established that between longitudinal and the radial mechanical pattern there is a vice versa relationship. So actually with increasing body surface area, with increasing heart rate, with increasing RV volume, radial motion will dominate and longitudinal motion will be decreased. Importantly, anteroposterior ejection fraction is rather determined by the left ventricular ejection fraction. So it is justified that this anteroposterior shortening is actually contributed by the left ventricular contraction. So it holds the promise to actually see the interaction between the two chambers to measure the contribution of LV function to RV function. What happens in pulmonary arterial hypertension? So pressure overload. In the clinical life, we see that there is a severe RV dysfunction and the longitudinal measures are still in the normal range. And this is happening because we think currently that the loss of the radial function, the loss of radial shortening, is an early indicator of pressure overload, and longitudinal shortening will be maintained for quite a long time during the disease course. Let's get back to our heart transplant patients, and this is a completely different mechanical pattern, as longitudinal shortening is severely decreased. However, there is a compensation, let's say, from the radial direction, maintaining global right ventricular pump function. We also looked at specific clinical scenarios like athlete's heart. We measured that there is an increased supernormal longitudinal shortening in elite athletes, and radial radial shortening is decreased. More interestingly, we found a strong correlation. I would not say strong, but there is a correlation between the cardiopulmonary exercise testing derived VO2 max. So actually the aerobic capacity of an athlete is correlating with the shift in the contraction pattern of the right ventricle, and importantly, this contraction pattern was measured during resting conditions. So a resting RV functional parameter is correlating with an exercise test derived functional capacity. Previously we conducted a little prospective study, and I think this is conceptually a great example of what we are talking about. So this was about severe primary mitral regurgitation patients when, first of all, preoperatively we established dominant longitudinal shortening. However, just after the mitral valve replacement repair, so the open heart surgery, there was an instantaneous shift and longitudinal function decreased, and there is now a compensation from the radial direction. Interestingly, however, after 6 months of follow-up, the normal RV mechanical pattern, namely a balance between radial and longitudinal shortenings, restored and became similar to healthy controls. And more importantly, all these changes are happened in the face of a maintained normal global right ventricular ejection fraction. In the study protocol, we have pulmonary artery catheterization, and we measured the gold standard measures of right ventricular contractility, right ventricular stroke work index, and we showed that the abnormally increased longitudinal RV function is associated with the postoperative RV dysfunction measured by the decreased right ventricular stroke work index. And we also, of course, would like to look at not just diagnostic value but prognostic value, and this is maybe one of the most important study of ours with revision method. We investigated about 300 patients with different left-sided cardiac diseases, and we separated 4 subgroups with normal left ventricular ejection fraction, mildly reduced left ventricular systolic function, moderately and severely reduced systolic function. What we were able to show that in parallel with the left ventricular systolic dysfunction, the anteroposterior and the longitudinal shortening of the RV decreases. However, there is a compensatory increase in radial motion. That means that longitudinal and anteroposterior RV mechanics are coupled with with LV dysfunction. However, there is a compensation by the radial shortening, which will maintain right ventricular ejection fraction at the stage of the very severe left ventricular dysfunction, where all of these 3 components drop, and also right ventricular ejection fraction will drop. Interestingly, we can also show that anteroposterior ejection fraction was similarly good in separating 2 risk groups concerning long-term adverse outcomes. But we also looked at patients with preserved right ventricular ejection fraction, namely values above 45%. And in that case, not surprisingly, RVEF was not performing well. However, anteroposterior ejection fraction was still able to separate 2 risk groups. What we think is that anteroposterior ejection fraction is a very useful parameter in characterizing ventricular interdependence, the LV contribution to RV function, and that's why it is predictive for future adverse events, and this predictive value is independent of left ventricular ejection fraction. Of course, RV function, RV dysfunction is of pivotal importance in different congenital heart diseases, and we have a study where we can show that even there is difference in the contraction pattern between transposition of the great arteries and congenitally corrected transposition of the great arteries. And interestingly, in TGA patients, the anteroposterior shortening dominated the contraction pattern. So this is a unique scenario. And honestly, all these measures, of course, are affected by preload and afterload. And we know that ejection fraction, longitudinal strain, and all these measures are affected by different loading conditions, and not just loading conditions, but also chamber geometry and other factors. So we are also thinking about adjusting for the geometry and loading conditions to actually better quantifying RV contractility. What I would not talk about today is RVPA coupling, which is actually a great concept in characterizing the pulmonary circulation, and also it is better prognosticator than the sole RV functional measurements. However, we are measuring, I think, RVPA coupling because we cannot measure contractility, which is the intrinsic function of the myofibers. And how about better reflecting RV contractility? And in that case, we can have more power for RV functional measures. So, as you may be aware, concerning the left ventricle, there is a software available that adjusts longitudinal strain to the instantaneous LV pressure, and these myocardial work indices are actually mitigate the afterload dependency of strain, and therefore revolutionized left ventricle functional assessment. However, we would like to think even forward, namely to adjust for preload and adjust for chamber geometry. On the right panel, you will see that we run a study, an animal study, and a little human study concerning the left ventricle. So importantly, we are talking about now concerning the left ventricle in volume overload induced left ventricular dysfunction. And what we can see is actually that if we further adjust pressure-strain relationship to the instantaneous left ventricular volume, then we can calculate such myocardial work parameters which are even better correlated with the gold standard measures of cardiac contractility, like preload recruitable stroke work. And in the human example at the bottom of the panel, you can see that these three-dimensional loops, like pressure, strain, volume loops, was able to quantify and show this function of the left ventricle even when the standard pressure, strain loop derived myocardial work indices and ejection fraction and longitudinal strain were all normal. So we would like to apply a similar concept to the right ventricle, namely to create pressure strain loops, and by adding right ventricular volume, in that case we can have the pressure strain volume loop, and we can quantify this loop. And I have an example here for your kind reference, investigating two different patients. One is completely normal patients with an ejection fraction of 51%, showing the pressure, strain, volume loop, and there is an overload patient with both pressure and volume overload with a dramatically different pressure, volume, strain loop with the same value of right ventricular ejection fraction and actually the same value of longitudinal strain. So we think that volume overload induced RV dysfunction, for example, accompanying tricuspid regurgitation, can be captured by such methodology, and we think that the next version of revision, which is hopefully coming soon, will be able to capture this important physiological concept, and we can define such measures that are better reflecting right ventricular contractility. Of course, there are also several other perspectives for such research. So if we can combine these in-depth measurements of RV function with conventionally available medical data, we can define disease-specific decision support systems. But I think the exploration of these RV mechanical patterns and the corresponding clinical data is already convincing that these are such new metrics that are worth to be included among the assessment of RV function. And but we face still a huge gap concerning how to quantify RV function. So according to a recent large-scale survey, 50% of echocardiographic machines have 3D imaging. However, in 44% of clinicians report only qualitative measures, no quantitation at all, no TEPC, no fractional area change, no 3D RVEF, of course, just saying that okay or not okay in their reports. And only 17% of clinicians use 3D echo frequently to assess the right ventricle. So we think there is a need for a simple automated solution that provides more powerful measures of the right ventricle to actually harvest that information which is in these three-dimensional data sets, which is actually in the hand of the clinicians by the 3D transducers, because they are having significant diagnostic and prognostic value compared to the conventional assessment. Our revision method is available as an online application. We can work with three-dimensional RV models and also with raw 3D DICOM data. So if you are interested, please get in touch with us, and we are happy to answer your question and demo our software. My conclusions, ladies and gentlemen, that there is a growing attention to the clinical importance of the RV, irrespective of which side of the heart is affected. There is a growing number of promising novel functional parameters which eliminate the limitations of conventional ones, and there are growing possibilities for advanced automated analysis and decision making in this field. Thank you very much for your kind attention, and feel free to get in touch with us. This webinar will be recorded and will be available online soon, and we will share it with you as well. And now I will turn to the possible questions here at the chat. I can see no questions currently. So thank you very much once again for your kind attention, and let's keep in touch. Thank you and have a beautiful day.